Okay, so yeah, challenges with medication management are huge. Medication reconciliation, number one. So keeping the electronic health record list up to date, making sure that patients are adherent to their medications. That's number two. And number three is prescribing practices of all the clinicians, making sure they're using the right medication for the right patient. That's the challenge. As we've moved into a new era, so instead of managing just small molecules, we're looking at biologics, and we have some programs that we've started on biologics the last few years. And as we've interviewed and we've spent time with clinicians, they're writing the prescriptions for the biologic for the patient. And that's where their therapy or their follow-up for the patient typically ends. They assume since they're writing the prescription, it's a high dollar, high risk, the patient really needs it, they assume the patient's adherent to the therapy. We're finding out that it's no different than any other chronic therapy where patients are adherent around 50% or less than 50% of the time. So getting the pharmacist involved in that therapy, we're actually able to de-escalate care where the patients aren't benefiting. So therefore the patient isn't put at risk for an adverse event of those high-risk medications or the disease-modifying therapy medications. And also the patient is then adherent or put on another therapy that they'll be adherent to get the same outcome at a lower expense. Again, taking the diagnosis and leaving it with the physicians, but taking the management to another practitioner, so an RN case manager, a pharmacist practicing at the top of their license to make the patient adherent. So it's a small number or a small percentage of patients, but it's a large percent of our spend in the ACO, so that's why we're targeting that population.